ladies and gentlemen. I'm Vincent Chung, Associate Professor of the Jockey Club School of Public Health and Primary Care, the Chinese University of Hong Kong. As the moderator, I welcome you to our last webinar of the Implementation Science Week. Implementation science, often referred as the science of getting research into practice, focuses on bridging the gap between evidence-based intervention and their successful integration in real-world setting. It is a multidisciplinary field that draws up on various disciplines such as public health, psychology, sociology, management, and many others. As the last seminar of this series, we will explore the new frontiers of implementation science. Throughout the next 2.5 hours, we will have the privilege of hearing from experts in the field who will share their valuable insights and experience. So the first lecture will be delivered by Professor Per Nilsen on de-implementation and other new topics in implementation science. In the second lecture, I will present on the adaptation of evidence-based peri-discharge complex interventions for witnessing 30-day hospital readmission amongst heart failure and COPD patients in Hong Kong. And the third lecture will be delivered by Professor Johnson Wang on using Consolidated Framework for implementation research to investigate facilitators and barriers to implementing alcohol screening and beef interventions among primary care physicians and nurses in Hong Kong. We hope that this seminar will provide a platform for knowledge exchange among participants and our experts. And I encourage you to all actively engage in the sessions, ask questions, or share your own experience and perspectives. Please type the questions or your thoughts at the chat box, and I will share it to the speakers for response. Since we only have limited time for Q&A, we will not be able to select all questions to response. So without further ado, let me introduce the first speaker, Professor Per Nilsen. He is a professor of social medicine and public health at Linköping University and a professor of implementation science at Halmstad University, Sweden. He is also our visiting professor. Professor Nilsen is an economist by training and Stockholm School of Economics, and he was responsible for building a research and educational program on implementation science in Linköping University, including a PhD course, which is running annually since 2011. He takes particular interest in applying concepts and theories from beyond implementation science for improved understanding of the challenges involved in achieving practice change. So without further ado, may I now invite Professor Per Nilsen to start his presentation.
Yes, thank you, Vincent. So I will talk about the opposite of implementation, which is de-implementation, and also touch on at the end a couple of fairly new approaches in implementation science. So I will talk about low-value care, which is sort of the opposite of evidence-based practice, something that is not evidence-based. And de-implementation, and what are the determinants for stopping doing something? And are there strategies for de-implementation? And some wrapping up discussion on the implementation, and then finishing with 2 new approaches on equity in implementation research, which has become quite popular, especially in the USA, and economic analysis of implementation, which I think is has been very much overlooked, because obviously it's important how much it will cost to implement something. Policymakers surely will be interested in that. So some of the presentation, I acknowledge a group from Karolinska who got funding 3 years in a row, slightly different projects, but everything was about de-implementation in various shapes and forms. So what is low-value care? But first, why should we care about the implementation? Well, it's because an evidence-based healthcare will require both implementation of evidence-based interventions, or we call it also evidence-based practices, interventions and practices which have proven effective in research. But we also need to get rid of non-evidence-based interventions, which is what we call low-value care. So implementation of evidence-based intervention plus the implementation of low-value care equals evidence-based health care. We usually are very concerned with the implementation part of this equation. But I think the implementation has become increasingly recognized as an issue, because it's difficult to just add on new practices without removing those lacking in evidence or being low-value care. So examples of low-value care: benzodiazepines for adults 65 years or older is said to be a low-value care, and also antibiotics for patients with respiratory infections. And many imaging and testing excuse me, can be low-value care. It's something that the patient requests, but there might not be any evidence that it is conducive to better health. So that's some examples. And why is a practice low-value care? It can be unsafe, ineffective. It can be ineffective for certain indications, like antibiotics for respiratory tract infections. That is low-value care. It could be unsafe for subgroups of patients with risk factors. Anything used in inappropriate dose or used inappropriately could be low-value care. And it could be low-value care if it's very costly. So it might be effective, but it's not really cost-effective. And there might not be any evidence whatsoever. So there are quite a few reasons for something being a low-value care. And what's the magnitude? How important issue is this? And I think this is an estimate that is quite subjective, but it's because it's not really measured. It's sort of more as an estimate that maybe like 30% of care is wasteful, and including being low-value care. And it could be overuse also. We say in Europe considerable wasteful spending in healthcare, but no precise numbers. USA has actually made an estimate that 11 to 15% of all patients received at least one low-value care service during a year. So we can see that it is quite a substantial problem, even though it's likely to be quite difficult to measure. And there are some recommendations and guidelines the sort of main policies against sort of trying to mitigate low-value care, and choosing wisely is an initiative. Still, it's not sufficient. And we have the guidelines, the do not do guidelines in England, NICE, National Institute for Health and Care Excellence. And in Sweden, we do have national guidelines, do not do recommendations. But identification of low-value practices, low-value care, and providing recommendations is usually insufficient for reducing low-value care. It still persists despite these recommendations. So how do we then de-implement low-value care? We first have to define the term. I have to move this. So the implementation is a structured and planned process using a set of activities to reduce or stop the use of low-value care. So it's sort of very planned, a rational process. And I think many terms are in circulation, abandonment or de-adoption, disinvestment. But I think the term de-implementation has probably become the most common. And it's also handy, practical, because we talk about implementation, and de-implementation is clearly the opposite. And it seems to be a growing topic of concern. And I think the 22 bar is it's not a complete year. I think this was done sometime mid or towards the autumn of 22. So I'm quite sure that the 22 bar is way above 21. So it's clearly, it's a bit like implementation actually, increase in publications over time. And this shows number of publications with the term de-implementation in either title or abstract. And here we have number of publications with the term low-value care in PubMed. Similar increase over time. So just like in implementation, we are interested in what are the determinants, what might be barriers to de-implement, and what might facilitate de-implementation. So it's very similar approach to understanding de-implementation. And we did a study, a scoping review, to identify determinants. We found huge number of papers and in many different fields or disciplines. Eventually 101 studies, 92 concerned determinants, 9 focused on determinants for de-implementation. So what did we find? First of all, we categorized them into 6 different domains or types of determinants. Had to do with the patients, had to do with the health professionals, the inner and an outer context, and process determinants. I will get to these. And also the evidence and the characteristics of the practice was one type of determinant. So essentially, we could use the same type of frameworks we use for implementation, the same types of determinants. And inner context, it could be, for example, lack of care continuity meant that if you meet a new healthcare provider, it's somebody who is not has the perspective of the whole care pathway. And it could be in other context, and especially I guess in some countries where more private healthcare marketing advertising for healthcare products seems to be quite important. And we also had what we call patient determinants. And here we have a clear difference with implementation, because implementation concerns something new, something the patient might not know about, be aware of. But in the implementation of low-value care, it might be that the patient knows exactly what he or she wants, but it might not have sufficient evidence. So here is a different case, that they know what is the practice that should be de-implemented. And we could see that worried patients are prone to think the more tests, the better. So this emotional attachment or emotional component seems to be quite important. And eventually we compare this framework in our scoping review with the CFIR, Consolidated Framework for Implementation Research, the most widely used determinant framework. And you can see that it's essentially the same. It's just a question of where do you want to put patients, for example. We felt that patient domain should be a domain of its own. In CFIR, it's actually part of, somewhat oddly enough, I think, part of the outer setting. But I guess they come from an outer setting. And we did another study, which was a grounded theory study, so a qualitative study. And we wanted to know, why do physicians in primary care use low-value care? So this was done in Stockholm. And the practices we had questions about in the interviews were vitamin D, sedimentation rate, and liver test. Semi-structured focus group discussions and a GT approach. And the overall findings, 3 overarching reasons why physicians use low-value care: an uncertainty and disagreement about what to do for the patient. There might be perceived pressure from others, from colleagues. And it could also be a desire to do something for the patients who have come to healthcare expecting maybe comfort and to get something. So the first here, uncertainty and disagreement about what to do. It was a case of being aware, is this medication low-value care or not? They were not always knowledgeable about that. It could also be that they felt that there were guidelines which seemed to be conflicting. It could also be that they felt the guidelines okay, they were okay, but they were irrelevant for this patient group, or a lack of trust in the source of the guidelines. So these 4 types of themes or categories made up uncertainty and disagreement about what to do. I think we'll skip this. And the next category, perceived pressure from others, and it could be pressure from the patients. They wanted something. They wanted a test or a lab test or a scan to be done, even though it might not be supported by evidence. Could also be pressure from other physicians, or it could be pressure from the healthcare system to perform unnecessary tasks. And here are the examples. Actually, quite interesting that pressure from the healthcare system to perform unnecessary tasks. Some physicians felt that too many healthy people should not come to healthcare, and they consider that low-value care, which it's not really in accordance with the definition. And the third domain or category was this desire to do something, and the sort of the visit prompts action. Symptoms needed to be relieved, even though the medication used for this was not the appropriate. And also this emotional thing that people also go to healthcare to be comforted or be reassured. This was a common quote. It's always nice to do something for the patient. Yeah, patients' emotions. Some argue that, well, it's easy to take a couple of tests so that the patient will let go of their worry and be reassured that everything is all right. And doing these tests might be low-value care, and it's also costly. So the 3 categories, and we can see there is an interdependency. So they influence each other. And they could also sort of enhance each other. So what are the strategies for de-implementation then? We looked in a scoping review, 310 studies, and we wanted to compare them to the 73 strategies of Byron Powell's ERIC taxonomy, expert recommendations for implementing change, where they list 73 types of strategies identified in the literature, so there might be more. And here are the 10 most widely used, and the green or blue bars show various versions of education and training. So 1, 2, 3, 4, 5, half of these, including the most widely used, is really about trying to educate away low-value care. And we also had the reminders and audit and feedback. So it's quite similar to the strategies used in implementation. Maybe here it's even more emphasis on education, that there is knowledge. The assumption being that there is knowledge lacking. And wrapping up on the implementation, Well, some key findings. It's attracting increasing interests. And we think it's relevant for also understanding the challenges of implementation. It's clearly multifactorial and multi-level, just like implementation, and clearly overlap of determinants, very similar actually. Of course, the relative importance of these determinants probably differs between implementation and de-implementation, but how is not clear. The impression is, although this has not been tested or measured, is that patients seem to have a more important role in de-implementation than in implementation. And many other strategies are the same. Some seem unique to de-implementation. For example, a communication tool to explain why it's not a good idea to use a specific practice. There would be no use for that in implementation. So thus far, there is limited development of theories, models, and frameworks specifically for de-implementation. Although it has been argued that de-implementation might require a separate theories. We don't know how useful they could be. So the key question here is the implementation low-value care more difficult or easier than implementing evidence-based practices? And this will be difficult to measure. So I would like to simply conclude that it's difficult to say. Because some behaviors might have to be increased and others decreased. Low-value care is complex. It might be evidence-based treatment for some subgroup in the population, and it might be low-value care for another subgroup. So some behaviors should be increased where it's evidence-based, and other behaviors might be decreased. So I think it's very difficult to say. Yes, this might be a difference, that the implementation might require a disruption of habits, a modification of culture, something that has maintained current behaviors, practices, and routines. You might have to disrupt the current practices, and that can be difficult, and probably not sufficient with only knowledge or training. So then at the end, a couple of new approaches in implementation science, and they have been more recognized if you go to implementation conferences, more papers, I would say, overall. So this equity, there's lots of papers on that now. Don't think there were any 5 years ago. So it talks about disparities in health and healthcare. We know there are significant differences in access, quality, and outcomes between groups. And I usually think socioeconomic status is a very key identity here. Maybe it's not called an identity, but it's a way to categorize. In the US, it's often much talk about race and ethnicity, etc. But health equity is defined or understood as fair access to opportunities for optimal health and well-being. And as it has been advocated, implementation science has not really addressed this. It's sort of an emphasis or increased push to do that. Why should we care? Well, it could be recognized as a special case of implementation failure, that maybe we succeeded in implementing new practice, but it increased health disparities. And also it's been argued that implementation science has two aims, both research and practice, and to improve the outcomes for those being served. And very much an increased emphasis on policies to reduce health disparities. So we will see how this develops. And the other new approach, which I think maybe is a more fundamental mistake not to address, is economic evaluation. Because whatever we find in our research, which strategies might be effective, there is also a cost side to them. And the cost could be the barrier to the implementation. It might be a very efficient practice, a new intervention, but implementing it, upscaling, spreading might be very costly. So it's defined as the costs here, cost over and above the costs of the intervention. So it's the costs for getting it into practice, for the strategies needed. It might be training staff, etc. And surprisingly enough, but I think mostly because they are difficult, there are few economic evaluations that, for example, compare the value of different strategies. And why should we care? Well, costs are an important determinant. And I think this is very important. I think some of the projects I've heard about here in Hong Kong, many policy projects, and I think the cost data is important information for policymakers, providers, decision makers. They need to know the full cost of implementing these evidence-based practices, not merely if they are effective or not, also what it will cost to implement them. And I think that was our final question. So if you have any questions, how do we do with it? Vincent, can you put them in the chat?
Yeah, sure. If you have any questions for Professor Nilsen, please type on the chat box.
Well, otherwise we can take also questions at the end.
Yeah, so just feel free to type if you have any questions. Okay, seems we don't have any questions yet. So maybe we can leave it at the end.
Yeah.
Or Johnson, you have any question? Okay, there's one question from Eliza. So
Yeah.
Eliza is asking whether we can use the TDF to identify factors for de-implementation.
I think so, and I think we found, I actually had some slides on that, but I thought there would be too many slides.
No. Actually, we have time. We have time tonight.
Yeah, but I removed them earlier today, but there are studies which have used TDF, so I think that would be totally fine to do that. And TMF's theories, models, frameworks we saw in another scoping review were essentially the same, and some were the same as in implementation studies. So I think that's definitely possible.
Okay. Okay, thanks. Thank you. So Johnson?
Okay, so may I introduce the second speaker of the night, Professor Vincent Chung. Professor Chung is currently the associate professor in the Jockey Club School of Public Health and Primary Care, Faculty of Medicine, the Chinese University of Hong Kong. And he completed his MSc in evidence-based healthcare in Oxford University, and he studied his PhD in the public health at the Chinese University of Hong Kong, focusing on health service research. So he is currently an International Health Policy Fellow of the National Academy of Medicine, and he has completed a Hong Kong Health and Medical Research Fund Research Fellowship from 2019 to 2021. And his research interests are in the intersection between evidence-based healthcare, health policy, and implementation science. And he has excellent publication record and has published more than 160 articles in the international peer-reviewed academic journals and ranked as the top 2% cited scientist worldwide in 2023. Oh, what amazing. According to the updated science-wide author database of the standardized citation indicators. So let's welcome Professor Chung now the time is yours.
Thank you, Johnson. So today I'm going to talk about a slightly different topic. It is related to implementation, but it is this preparatory phase of implementation. We all know that when we try to implement something in a new context, we may have to make some adjustment on the nature or the features of the intervention so it fits into the context. So today I'm going to introduce a possible way of actually promoting the intervention and the context fit. And then through this way, we may be able to better implement a new intervention to a local health system. And we'll use the avoidance of 30-day unnecessary hospital readmission as an example. So we all know that avoidable hospital readmission is a key policy problem among many of the healthcare systems globally. Here in Hong Kong is no exception. And heart failure and also chronic obstructive pulmonary disease, COPD, are the two leading causes of hospital readmission. And there are many ways for us to reduce these unnecessary readmission. And they are very often complex because, as you can imagine, if you want to prevent readmission, you have to start doing something to prepare for the patient and the caregiver before the discharge. And at the moment of discharge, also you need to make appropriate arrangements so you can transit the patient's care to primary care and also in the community. So there are many components, and that intervention involves multiple levels of a healthcare system, all the way from secondary care or tertiary care down to community care. And clearly, this is an example of complex intervention, because complex interventions are defined as interventions comprising of multiple interactive components. And this is this kind of peri-discharge intervention for reducing avoidable readmission is a classic example. And the key goal of orchestrating such a complex model of intervention is to ensure a seamless transition from inpatient to outpatient and community care. The complexity and the components of these complex interventions, of course, will be different according to the features of the healthcare system context. And these kind of interventions should also be tailored to the needs of different populations in different health systems in different countries. And therefore, now we have an issue. The intervention per se is complex, and there's another layer of complexity because we have variations in health system features and patient needs. So when we look at international evidence on the effectiveness of peri-discharge complex intervention, we find a lot of different types of complex intervention that may be contributing to beneficial effect in reducing readmission. But we know that despite we know what sort of things may be useful, the benefits of this intervention may vary across contexts. And for Hong Kong, even if we want to make references to this existing international evidence, we have to adapt them before implementation. But how to do this? So we have come up with a study to try to adapt evidence base, those with network meta-analysis support, complex interventions from that we tried from previous work, and we try to tailor them to fit the context of the Hong Kong public healthcare system from a local stakeholders perspective. So this is a process of moving international evidence base to the Hong Kong healthcare context. And we use a model of our framework to guide our adaptation. So to translate evidence-based complex intervention into locally adaptable intervention option, we use the GRADE evidence to decision framework. And this framework considers 7 criteria when we try to make decision on whether to use a particular intervention or not. This includes the priority of the problem, benefits and harms of the intervention, values and preferences of the patients and the caregivers, resource use, feasibility, accessibility, and equity. And this provides a very transparent framework for us to engage stakeholders to work together with us to adapt the complex intervention into a new healthcare system context like Hong Kong. And this can ensure that the discussion will be comprehensive and also structured. So now we have the method section. So now we start with the international evidence, right? So we have to prepare and communicate the evidence to the stakeholders. So we have all these comparative effective results from different peri-discharge complex intervention generated from network meta-analysis, and we create these quite complex evidence profiles. So this is the first step of using the GRADE evidence to decision framework, because the first thing is evidence, but you have to present it in a clear way. So network meta-analysis per se is quite a complex endeavor, trying to find out what may be the best combination of different intervention components that give you the best effect in avoiding readmission. So we will look into the possible effectiveness ranking of different complex intervention, the quality of evidence, and we provide interpretations of the findings to the stakeholders before we actually engage them for discussion in making decision. So you can see we need to spend a lot of time, prepare and train our stakeholders in order to allow them to understand what the evidence is about and how to interpret these findings. So I won't spend a lot of time on this epidemiological concept, but eventually we successfully educated and recruited very important stakeholders. And these stakeholders are actually frontline healthcare providers or experts in the field. So they have first-hand knowledge in delivering relevant services in our public healthcare system already. So these experts are coming from A&E departments, convalescent hospitals, the community geriatrics assessment team in Hong Kong, which provide community-based care for discharged patients. And of course, for the heart failure disease, we engage experts from the cardiology department. And we also engage university professors from cardiology division and the nursing schools. So there are in total 18 experts engaged in the heart failure panel. And we did the same for the respiratory panel, except the fact that we replaced the cardiology department with the respiratory medicine department. So after creating these 2 expert panel, then we carry out a 2-step process for both of the conditions. So based on the evidence profiles we provided and also our training, each of the stakeholders use their own personal local practice experience or academic expertise to contribute to, number 1, prioritize the evidence-based peri-discharge complex interventions. Because you know that when you're doing a network meta-analysis, you will generate a lot of options with their comparative effectiveness ranking. So whether a particular highly ranked, highly effectiveness complex intervention package will be applicable for Hong Kong or not, we have to ask the frontline workers to comment on their appropriateness. And then after prioritization, then we have to formulate recommendation on the prioritized complex intervention based on a two-round Delphi survey. So we know eventually what sort of complex intervention we should actually be adapting for Hong Kong that will fit into Hong Kong's special circumstances. So for step one, in this step, the stakeholders in the panel were asked to provide a judgment on the following 6 criteria for prioritizing evidence-based peri-discharge complex intervention. So as you can see, they are different from the GRADE ETD, evidence to decision framework for making recommendations. And these criteria place special emphasis on local, contextual, and organizational factors. So we look at these local factors first to prioritize before we make decision. So number one, what is the local burden of readmission? If we have very, very complex package, which involve a lot of manpower and cost, and we have a high burden of readmission already, probably we cannot provide that much resources, right, to support such a complex program. And also whether we have some existing initiative already in this field, or in which the existing evidence also support the current practice, and there's no need to train, or will we just adapt them or add some new elements to it? So the second issue will be appropriateness of current practice patterns. Number 3 may be ongoing controversy. Maybe there are some elements that some experts think is appropriate and some other experts find it not very useful. So we can use this opportunity to discuss and see whether the evidence support this controversial intervention and whether we should include it or exclude it in the prioritization process. Then we look at whether we have availability of well-developed local guidelines for some existing practice, and we can use it to support our new program. And finally, what would be the perceived health impact as indicated by the potential effect size of the chosen complex intervention, and finally, methodological quality of the current evidence. So after considering these 6 criteria comprehensively, each stakeholder will be invited to determine the importance of each intervention by doing this quantitative survey. So after considering all these criteria, the 6 criteria, they are asked to weight the intervention from score 1, not important, or score 5, very important. And also we invite the experts to be creative and give us some ideas on combinations of different complex intervention. So they are invited to suggest on any combination of complex intervention for reducing unnecessary readmission in the Hong Kong context, and they are free to give any combination. So this is basically just like going to Subway to create your own sandwich, right? You can add in or you can delete certain of the food that of your choice, or of the vegetables. You can choose meat, and in our case, it's the same. So if you want to create a new program for the patients who are at high risk of hospital readmission, what sort of intervention component you will add? Will you add telephone follow-up, or nursing intervention in the community, or patient education, or caregiver empowerment, you name it. So they are being creative in making up their own complex intervention that they think which will address the unique features and needs of the Hong Kong population's patients. So we do an analysis then. So 1 mark is given for weighting as not important, and 5 is important. So for each of the panel and for each of the intervention, you have a total score of 90, because we have 18 stakeholders, and if they all give a 5 rating, very important. So the maximum score for intervention will be 90. So an intervention was prioritized and then considered for further evaluation in step 2 if the total weighting score was larger than 50%. So therefore, if an intervention is weighted higher than 45 marks, then this intervention will be considered to be prioritized. And also the most important combinations suggested by the 3 experts or above were also prioritized and considered for further evaluation in step 2. So in step 2, we have to start formulating recommendations on the prioritized complex intervention based on the 2-1 Delphi survey. As I mentioned before, for the prioritized intervention, they have to think about whether this will address the problem in a priority way. What is the potential harms and benefits of the intervention? Will the values and preferences of the patients and caregiver affect the use of certain complex intervention? Are they very resource intensive? Are they feasible? Will they be acceptable from the health system perspective? And whether that will promote equity as well. So again, for each of the prioritized complex intervention, stakeholders were invited to determine the recommendation level after comprehensively considering all the criteria in the ETD framework. So for this one, for example, as we show that, we have a complex intervention called supportive educative intervention, and this is actually containing 4 components. So these components include the patient education, medication intervention, self-management, three components. So we asked whether these 3 components should be combined together to create this package and be implemented. So the expert can weigh against this option or recommend this option. So for the Delphi 1-1 questionnaire, we calculated the median weighting, the interquartile range, and also the percentage for agreement. We collected qualitative comments from the stakeholder also in order to understand why they're making such choices. So for those intervention with more than 70% of the stakeholder weighted suggest this option or recommend this option, this will be considered as a complex intervention with positive consensus, and this will be considered as being endorsed by the stakeholder group. And on the contrary, with more than 70% of the stakeholder weighting not suggesting this option or recommending against this option, the intervention will be dropped because this is a negative consensus from the panel that we should not do this one. And for those we have neither positive or negative consensus in the first round, we will then conduct a second round Delphi questionnaire and repeat the process to see if there's any further progress in making more consensus for additional complex interventions. So for round 2, because we want to make sure that the stakeholders can communicate with each other and explain why they are agreeing or disagreeing with a particular complex intervention, a Zoom meeting within each panel was conducted to facilitate stakeholders' discussion on their weighting in an online environment face-to-face in light of their knowledge of how others are weighted. And of course, we didn't attempt to force the panel to come up with a consensus, but we let them to re-weight those interventions without a consensus. So after the meeting, each stakeholder was invited to give a judgment on the elements of the ETD framework again in Delphi round 2. So for this one, after discussion, we will provide stakeholders with their own weighting in round 1, the median weighting with the interquartile range and percentage agreement for each of the interventions, all qualitative comments presented in an anonymous way, and also assessment result for each element of the ETD framework from all other stakeholders, so they can have a comprehensive understanding on what the disagreement is located. So then we perform, again, data analysis similar to round 1, and then we generated a list of finalized and endorsed intervention for each of the conditions. So here is the result. We have 2 intervention package that is rated very highly for heart failure. They are intervention 2 and intervention 4. So as you can see, intervention 2 is relatively more simple with only 3 components of medication intervention, patient education, and self-management. But intervention 4 is much more complex, right, with more elements. But you can see some patterns as well. As you can see, all those words highlighted in purple, they are actually shared elements or common elements that appear in different agreed intervention for heart failure management. And these are the results for the COPD. And intervention 4 has the highest rating. We have more than 90% of agreement for promoting we avoidance of readmission use provider continuity, we have discharge planning, and also self-management. And again, we see some echoes or echoing of those elements agreed by the heart failure panel. And after analysis, we located there are actually 5 common components for both COPD and heart failure. They're case management, discharge planning, patient education, self-management, and telephone follow-up. So this seems to be the magic recipe, okay, for helping different types of patients, that is HF and COPD patient, to receive their care in the community and at home and avoid them from coming back to the hospital. So this seems to be quite an important finding. So we know what should be the core elements of such a complex intervention. So for the discussion, so by applying this framework, GRADE ETD framework, a list of local stakeholder endorse the evidence-based complex intervention is created. And among those adaptive intervention, 5 common components were discovered. And of course, they should be considered to be a priority for further implementation and testing and adaptation in order to help the majority of the patient here in Hong Kong. So what are the implications? What's so important, or what may be the theoretical implication of our work? So actually, there is a recent process model being published for guiding refinement of complex intervention into new contexts, and this is called ADAPT guideline. And the full text, I think, is published recently in the BMJ. So in the ADAPT guidance, there are 4 steps involved in adapting a complex intervention. So of course, you have to start with an adaptation team comprising of diverse stakeholders. And our current approach actually informs how the step 1 of the ADAPT framework can be operationalized. Because in step 1, the key goal is to assess rationale for the intervention and consider the intervention context fit of existing interventions, right? So for the rationale of intervention, we have come up with 2 network meta-analysis to provide the evidence base to make subsequent decision. And the subsequent decision will have to consider the intervention context fit, right? And the GRADE ETD framework gives us an opportunity to achieve that. And so therefore, I think this is the major contribution of our paper, because there's no existing guidance on how to operationalize step 1. So this is actually a key contribution of our work. And of course, in the future, we have to continue to adapt the subsequent steps, okay, especially the 5 core components that we have identified. We have to do more work. So now we have potentially suitable, useful intervention selected for adaptation in our public healthcare system. And the step 2 is to plan for and undertake adaptation. And in step 2, in the future, we will have to identify contextual barriers and facilitators to this complex intervention implementation. So for example, we can use a CFIR to find out what the determinants are, and then we can generate tailored implementation strategies based on ERIC, for example. And finally, we then have to establish consensus on the proposed implementation strategies for these 5 core components, again, using Delphi techniques as well. And then we can move on to step 3, to plan for and to undertake piloting and evaluation of these new complex interventions. So the extent and types of evaluation required can be determined by the nature, quality, transferability of previous evidence. As you may be aware, our decision to choose this complex intervention comes from network meta-analysis of trials done in other health systems. And therefore, there's indirectness of the evidence when we try to apply the result in the Hong Kong healthcare system context. So therefore, maybe there are important uncertainties about their effectiveness in our new context in Hong Kong, and a new evaluation of effectiveness, cost effectiveness, and also process evaluation may be conducted along with implementation as well. In our result, I think a hybrid implementation effectiveness trial can be done. And this is actually suggested by our stakeholder as well for assessing context-specific impact of those 5 core interventions. So as you may already know, there are 3 types of hybrid implementation effectiveness trials. So step 1 actually tests the effectiveness of the adaptive intervention on clinical outcomes, which is the primary aim, and it has a secondary aim of evaluating real-world feasibility. And for type 2, it's more balanced. It simultaneously tests the effectiveness of the adaptive intervention, as well as the implementation strategies and co-primary aims. And finally, type 3 implementation trials focus on the effectiveness of the implementation strategies as the primary aim, and on the other hand, the clinical outcome will be the secondary aims. So the type of hybrid trials needed for step 3 depends on which aspects are considered to be most uncertain. So for example, in this study, there's no existing evidence supporting the effectiveness of the combination of our 5 core interventions in the local setting. And further implementation and also outcome evaluation is therefore needed before a large-scale implementation of our result in the whole hospital authority. And I think type 1 hybrid implementation effectiveness trial will be quite applicable to test the effectiveness and implementation outcomes. So if the intervention are considered to be effective, cost-effective, and feasible to implement in the local context, and then step 4 should be carried out. And in step 4, we focus on implementation and maintaining the adapted intervention at scale. So following efforts should be made to help this process in the future. So number 1 is to build a sustainable partnership, capacity, and plans for maintenance in continuing the application of these complex intervention. We need to establish a system for monitoring long-term implementation and effects. So that has to be transformed into a learning health system, so we know how we are doing and whether this complex intervention is actually continually to be found to be useful. And we have to report the final intervention for scaling up and for other people to learn and implement in their own hospital and community setting as well. So we have to report each of the interventions very clearly using existing reporting guidelines. Of course, there are some limitations in our study. We have used purposive sampling of participants through the investigators' professional networks, and that may induce researcher bias in the selection process. But nevertheless, we believe that the impact of researcher bias will be minimal, as the local stakeholder endorsed the peri-discharge complex intervention could not be established unless all the participants with different background, they arrive at the same consensus. And also the endorsed intervention were generated without the involvement of the patients and caregivers who will determine the acceptance and success of the intervention. And so therefore, in the future, we have to involve them to co-produce the intervention in detail. And also we have to think about the implementation strategies with their input as well. So in conclusion, we have applied a new framework to start the adaptation process of complex intervention, especially the step 1 of the ADAPT framework. And we have successfully established a list of local stakeholder endorsed complex intervention for preventing local readmission as well. So we suggest that before we scale up this intervention in Hong Kong, further study for improving intervention context suite, including involvement of caregivers and patients, and also assessing real-world implementation effectiveness using type 1 hybrid trials are needed. So thank you very much. And our work is supported by Health and Medical Research Fund. And the whole publication, whole study is now published in Health Policy and Technology as well. So thank you very much for your attention. If you have any questions for me, so feel free to ask it in the Q&A box, in the chat box. Thank you.
Thank you. Thank you very much for Vincent's presentation. It's a very interesting and important study. So may I know whether there is any questions from the audience?
I can ask one question to Vincent.
Sure, please.
Yeah. This Delphi expert panel, I think it's been used also for developing strategies for alcohol interventions in healthcare. What do you think, Vincent, are the pros and cons of this method?
Okay, I think the major limitation is people will question about the representativeness of the expert panel, because inevitably we have to engage people who are willing to contribute, and that will involve some sort of personal relations with the stakeholder. So we have very senior hospital administrator in our research team, and through his link, we have identified very engaged healthcare professional to join. But then there may be researcher bias, and as you know, within a healthcare team, we have some hierarchy as well. We may have some experts who will dominate the discussion during the Delphi process. And therefore, we have to make sure that our part 1 Delphi is all anonymous, and there's no discussion amongst all the stakeholders, so they can write their qualitative comment anyway as they can, and also provide rating without any influence from others. And in step 2, also we separate the discussion and the Delphi rating in 2 separate processes. So for the discussion, of course, we may have people who are dominating the discussion, but then people are free to rate whatever they want in the step 2 Delphi, because that's a separate process. They can do it after the discussion. So we try to minimize the problem of having people dominating the system. But still, this is only, of course, these are key stakeholders, and this is also accepted. We successfully identify some elements that is being accepted by a wide range of professionals. But when it comes to implementation, we know that the patients and the caregivers are key people who we should have involved in. But if we involve them in the Delphi process, that will be quite difficult, because we don't expect that our patient will understand the evidence. They don't understand how the community care work, how the hospital work. So at that stage, we cannot incorporate their views, and this has to be separated. So when there are disagreement between our future exploration on patients' view and the healthcare providers' view, this will cause us some headache, and we have to find a way to resolve this discrepancy as well. So I think these are the main limitations.
But I guess any method has limitations, so it's unavoidable, I guess.
Yes, indeed.
Okay, thank you very much.
Thank you. Okay, so
and I have a very brief question for Vincent. So so it seems that they have to be, the panelist has to be very familiar with the ETD framework before they can answer the question. So so did you have any measures to ensure all the panelists they are already very familiar with those framework before they start their Delphi?
So this is what we do. We actually create an online course on the basics of network meta-analysis. So we aim to educate our expert on how to interpret the results, and also a very brief education program on the evidence to decision framework with examples. So they have to complete the videos first before we will send any of the materials to them. And of course, inevitably, they are not students. They will not be, 100% be absorbing all the information. And they come up with so many questions when they try to do the ratings and try to understand our evidence profile. So what we do is to do individual phone calls or Zoom sections with them, so we can actually explain the information to them one by one. So this is how we did it, to make sure that people understand what we are doing. And luckily, it's only less than 40 experts, so we can still afford to do it with a very small research team. But if we have very complex panel involving different discipline and different background, I don't think we can do it. So basically private tutorials for the experts. So this is what we did.
Yeah, that's impressive. Thank you.
Thank you.